Hi, I'm Dr. Kenneth Adams from Pentucket Medical Cardiology, and I'm happy to be hosting this session of Matters of the Heart. I'm happy to have Dr. Seth Bilazarian here with me today, and the topic that he's going to discuss is performing heart catheterizations from the wrist.
Great. Well, thanks, Ken, for the introduction. So this is a topic that we've been talking about in our professional society. You and I actually been talking about it for some time, but it's been something that I've been thinking about bringing to our program here at Matters of the Heart, but I was stimulated this week because our hospital librarian sent us an article from the Wall Street Journal this week in the news about this and how it's becoming a more prevalent thing in the United States for us to do this catheterization procedure that's pictures of the arteries of the heart from the wrist rather than from where we've been doing it mostly in the past, which is the femoral artery or the groin artery. So I want to talk a little bit about that, to introduce this to our audience and to talk a little bit about it. There are 1 million catheterization procedures done in this country annually, and it's said that only about 7% are currently being done from the wrist, but that number has been increasing. We like to think of the United States as being very forward and very progressive and being leading the world, but actually in this area we're way behind. Countries such as Norway, France, Canada, Japan are way out in front, maybe doing as much as 75% of the time from the wrist artery. So I want to talk a little bit about it. I'm excited to hear your views as someone who does this procedure as well, and talk a little bit about some issues about this in general. But the procedure is important that we do this procedure to take pictures of the artery. It's our best way to evaluate heart artery blockages, to evaluate whether someone has a blockage causing anginal chest pain. We've talked about the issue of coronary artery disease on this program in the past. And the catheterization is a procedure that tells us first if there are artery blockages, and allows us to fix it also using an angioplasty procedure or stents, as many people have heard of. So this article, as I mentioned, discusses several interesting things that I enjoy reading about, because many of the issues about why it's been slow to adopt in the United States are things that I know I felt, and I'd be interested to hear whether you felt it as well. When people started talking about this several years ago, maybe 5 or 7 years ago, I was interested in it. I'm always interested in having new procedures available so that I can offer my patients the most progressive and new thing. But I said, you know, why? I've been doing this procedure from the groin my entire career. I've done thousands of procedures from the groin. It doesn't make sense to take on a new procedure. An interesting article was in one of our journals, Cath Lab Digest, that this journal is edited by a cardiologist in California named Morton Kern, and he tells the story of how he visited a cath lab in Quebec, Canada, that does almost exclusively procedures from the wrist, and was very impressed that they had very low complications rates compared to the complication rates of bleeding or bruising from the groin artery. And when he went back to California from Quebec, he went through this process that I know I went through, but interested in whether you went through as well. You know, should I do it? Why do I need to do it? Can I continue to do the procedure the way that I know how to do, that's fast and easy and good for me? And I think at the end of this, my impression has been that it makes sense for us to do this procedure, because I think it really is safer and it really is much more comfortable for patients. So that's the reason why I made the effort, and that you have as well, to try to take this on. The database from the United States is called the NCDR Database, a national database that the National Institutes of Health runs. They looked at 500,000 of these procedures, and they found that using this procedure had much lower rates of bleeding and bruising, less than half the incidence of bleeding and bruising. So we have a procedure that we know we can do. We know that is safer. We know that it's more comfortable for patients. I'll talk a little bit about why that is at the end of the procedure, at the end of this talk today. So really, the worst part of the procedure is for us as operators to take on a procedure that's new, to learn the procedure, to be able to do it in a way that's efficient and safe for patients. And there's this process that other people talk about in other industries, in other professions. It's called a learning curve, and we have to go up the learning curve, and as we become more proficient, eventually we get to be as good at this as the groin or femoral approach, but it takes some time and some investment.
Well, it's interesting that you said, gee, the United States is behind, and you mentioned some of the reasons why, like maybe this is a better procedure, it's more comfort for the patient, maybe fewer complications, but I had the same feeling as you, having done these procedures from the groin area for so many years and feeling comfortable with that, and I had to be convinced that this was a good way to go by doing it from the wrist. So any other advantages that you
Well, I
can
think that the things I would mention are certainly lower complications rates, which is, has to be high on our list. Of course, anytime we do a procedure, we want to have low complication rates. So that's important, number one. Number two, the patient's just comfort after the procedure. After the procedure, we'll skip a little ahead, but I'll tell briefly, the patient ends up with a wristband instead of having to lay flat for 4, 5, or 6 hours. Right. So that's an issue. And the issue of being able to get up immediately. Some places around the country have instituted what they call cath lab cafes, where after the procedure, patients can just sit and have a cup of coffee because you don't have to be laying down after this procedure, you just have a wristband on. So, and then add to that, I would say, is the length of stay in the hospital, which is a cost for patients and for health insurers. So if you could do a procedure that takes less time, is safer, is more comfortable, and the only downside is it's harder for the doctor to learn. You have to say doctors have to step up and learn it. I guess that's what we've done, and that's, I think, a sensible approach.
And just from a point of perspective, because I'm a little bit older than you, okay. When we first started doing catheter, or when I first started doing it, we'd actually have to make an incision in the arm near the elbow area and thread the catheter in. It was very tedious, and it was minor surgery. Right. So when we first started doing them from the groin area, it was a great improvement. And it sounds like radial artery or catheterization from the wrist is an improvement beyond that.
Yes, I think that's a great way to think about it. I mean, the other way to think about it, in addition, when we went to the femoral artery, you also remember that we used to put these 10-pound sandbags on people. Right. So they had to lay still for 6 or sometimes because our catheters were larger, that we had to lay them in bed for 8 hours, or overnight we would keep people in bed. And the sandbag, a variety of issues, was very uncomfortable. So now we have a procedure that a patient can have, end up with a wristband, go out, sit in a chair, have a cup of coffee, and go home in a few hours. So there are some pluses and minuses. It's not right for everybody, and I'm going to talk about that. But I want to just talk about the procedure a little bit. So someone who might have this procedure, and either watching this program or in the future watching on our website, can watch this program and hear a little bit about the radial artery catheterization procedure. So briefly, I'll just say that the radial artery catheterization procedure is done from the radial artery. There's 2 arteries in our wrist. There's the radial artery, which is on our thumb side, and there's an artery on the other side, the little finger side, called the ulnar artery. And the reason why this procedure is thought to be very safe is that if we block the radial artery by putting a catheter in it, blood flow can still come to the hand very well from the other artery and comes through something called the palmar arch. And what we're showing you here is a picture of the test that we do. It's called the Allen test. And the thumbs of the doctor are blocking both of those arteries, the one on the thumb side called the radial artery and the one on the little finger side called the ulnar artery. And we actually block the blood flow. We have the patient hold the fist tight as they can. And then, next slide I'll show, if we go to the next picture, I'll show we'll ask the patient to open up their hand. And when we open up the hand here on the left, the hand is actually very white because there's no blood flow. It's not dangerous. It just happens for a minute or so. You can see the hand on the left is very white. And then we let go of the finger that's blocking the hand, the artery on the little finger side, and we see if blood flow comes in. You can see the hand pinks up very nicely on the right side of the picture. So this is called the Allen test. We do a test like this. It's a little bit more sophisticated, called the Barbeau test, using an oxygen sensor on the finger, that oxygen test that we use from the thumb. It's the same sort of concept. We can either do that test called the Allen test I just showed, or this test called the Barbeau test. Either one of these tests helps us know that this other artery, the blood flow to the hand, will be good while the catheter is in the wrist artery.
And that's different than doing it from the femoral artery in the groin. Right. I mean, you might want to explain that to the audience.
And I'm happy to have you say that, but I'll just briefly say that the femoral artery is about 4 or 5 times bigger. So when we put our catheter in it, we're sure that there'll be no blockage of blood flow to the leg. So that's the difference. But this artery is smaller, and actually when we put the catheter in it, it blocks up the blood flow in that artery. So that is an issue. So we want to make sure that the hand's going to be okay during the procedure and afterwards when we do the radial artery catheterization. So the next picture, once we've established that that's A-OK, it's similar to other procedures. I'll show the next slide. And it's basically a picture of us just putting that catheter in the wrist artery. We numb it up with some Novocaine or lidocaine type medicine so the patient doesn't have any kind of discomfort. We put the catheter into the wrist artery, and then we proceed with the catheterization after that. So I'll just talk a little bit about that. So that's basically the procedure of putting the catheter in the wrist artery, and then we go ahead. Now, this procedure is very successful. As I mentioned, there's a learning curve, so it takes some time to get up to speed. There are sometimes things that we don't expect. And in older patients, sometimes we have a thing called a radial artery loop. And I'm going to show that in a second, but basically we can't know before doing this procedure whether we're going to have one of these. But basically it's a loop-to-loop, sort of like a roller coaster, either up in the elbow area, or you can also have one up in the subclavian area, up here near the shoulder. So you can have a loop-to-loop that you can't get your catheter through. So that's a concern that's potentially something that we'll find even after we put the catheter in, and we have to just stop. The good news about it is the same good news about radial artery catheterization is we take the catheter out, we put a wristband on, and we can either go to the other wrist or go to the groin, and we haven't really caused any harm or problem.
That's very clear. Just tell me, do you think patients feel the wristband is uncomfortable, like the sandbag is uncomfortable in the groin? Have any patients said anything about the wristband being a problem?
In generally, patients who have had both of procedures, I've had many patients now who had a femoral artery catheterization many years ago. I've been doing almost exclusively the radial artery catheterization for a couple of years now. So in the last couple of years, patients have had both. And there's a rare patient who said, I'd rather have the femoral over the radial artery.
Yeah, that's
almost all patients say I'd much rather have the wrist. If I ever have to have it again, please do the wrist.
Yeah, that's my experience also.
Okay. So I'll just show a picture of what this radial artery loop looks like. The next picture. And you can see that on the left it says complex radial artery loop. It's actually a loop-to-loop. It actually goes around the full 360-degree loop. So when we bring our wire up that we use to snake up in, if we find this, we actually may just decide for taking a picture, it's too complicated, it's too dangerous, let's just stop and not proceed. Some of them aren't so bad. Some of them are just twisty and you can go through them. But if they're really these hard loops, sometimes it's safer just to stop. So this procedure, when patients go into it, they have to know, and I do say we're 100% successful, or very close to it from the femoral artery. We're 96, 97% successful from the wrist artery. So patients have to know there's a couple of % chance we'll try, but we'll have to go to the groin anyways. Most patients, knowing that, would still rather have the radial artery approach. I'll just show the next picture, if I could. This is a picture of what we're talking about. So you can see that from the wrist, you can see on the right side of the screen, we go up the radial artery, up into the chest, into the heart. The old way was from below, coming up from below, from the femoral artery up to the heart. Both ways are acceptable and good ways to get to the heart. What we're really finding is that the big deal here is the difference in bleeding and complication issues are lower from the wrist. The big deal from our standpoint is it's a lot more difficult. It's harder to do for us. So when we're at the beginning of our learning curve, it takes a little bit longer to do the procedure. We may have to use more catheters to change. But ultimately, we get the results that we're looking for. We get good pictures so we can answer the question, do you have blockages? We do have the ability to fix the artery with stents and whatnot. And the patients are much more satisfied with comfort afterwards.
Yeah, I think the patient comfort is really a high priority, and you're right about the learning curve. When you first start doing this, after having done the femoral approach for so many years, it's, oh boy, do I have to do this? But when you get the feedback from the patients and they're so happy with the recovery, it really stimulates you to want to do more.
Right. Well, I will say, though, that one thing, we don't have any, I'm sure we have no doctors in our audience, but one thing that's been a recommendation for for us as we go through the learning process is to not do this procedure selectively in just the patients who might be high risk, and I'll talk about that in a second, but to do it in all patients, because then, of course, you accumulate more success, and you do it more often. The patients that we definitely want to do this procedure in would be patients who are very heavy. And the reason for that is a patient who's very, very large, who's fat, to use the term, or obese. Those patients are at very high risk for bleeding because, as you can imagine, the very big belly can make it very difficult to block the bleeding that can occur after a catheterization from the groin. So in those patients, we feel it's very desirable to try to do the wrist because even if someone's heavy, there's no issue about causing the bleeding to stop with the wrist artery site. But if doctors use this just in heavy patients, so they're only doing it in 10% of their patients, it's much harder to accumulate the comfort and the experience and the expertise to be really good at it. So that's one of the encouraging issues.
Now of course, everyone's got two radial arteries,
right.
One on the left, one on the right. How would you decide whether to go from the left arm or the right arm?
Great question. So the issue, I think, is a couple. There have been studies of this, and the studies are we're less likely to run into trouble if we use the left wrist than the right wrist. So my advice to doctors as they're starting has been generally to try to use the left wrist as much as possible because you'll get more confidence, you'll be able to do the procedure. But there are a couple of issues. One is if the patient is very large, our tables are set up to work from the right side of the patient. So if the patient's lying down and we're on the right side and we do the left wrist, we have to reach over them and reach over their belly to do this procedure. So that can be difficult if they're very large. But the left wrist is preferred for that reason mostly. The other patient set that seems to be preferred to use the left wrist are shorter patients. I won't go into the details, but generally if you're shorter than 5'6", the left wrist is preferred than the right wrist. So generally in a patient who's shorter than 5'6", I generally try to use the left wrist whenever possible. Another patient population that I use the left wrist in is the heart attack patients. Now, we sometimes do these procedures to patients when we're just looking. They're elective procedures, so there's not a rush to do them. But in our patients who are having a heart attack, we believe that every minute counts. So we want to get to the heart as quick as possible and open up the blocked artery that's causing the heart attack. So in those patients, I want to do everything I can to reduce the issues that might delay me to get there, so I use the left wrist in the heart attack patients whenever possible. And the last thing is that patients who have bypass grafts, a common bypass graft is an artery that comes from the chest wall. And that comes off the artery, actually, that we're going right by. So if we use the left wrist, it's very easy to take a picture of what's called the left internal mammary artery or the Lima bypass graft. If you go from the left wrist, it's impossible to get that if you go from the right wrist. So if you do the right wrist catheterization and you have a Lima, you can't do it. So we always either do the groin or the left wrist in bypass patients. So I think that's the differences in the two. I think either one is fine. I think the left wrist is actually preferred, and some operators around the world do almost all their cases from the left wrist. But for us as operators, it is a little bit nicer to do the right wrist because we're on this side of the table.
Exactly.
But your question brings up another concern that many operators are concerned about, and that is if we do the left wrist, we're sort of laying almost across the patient, and there is greater radiation exposure for us as doctors who are doing the procedure. There are some ways to work around that. We're working around that at some of the hospitals that I work at and using drapes for patients and other kinds of strategies to try to reduce the radiation exposure to us. But I think that it's a physician preference that I don't think is right or wrong. But I think those are general guidelines I gave you. Left wrist for bypass patients, left wrist for shorter patients, and left wrist probably for most of us as we're first starting or where time is of the essence.
Now, you mentioned that in the United States we're doing about 7% of these from the wrist, but you're doing most of yours from the wrist. Do you think that this is going to change in a big way in the near future?
Well, I do think that one of the drivers, of course, of medical care is cost and insurance. So one of the things that we believe is going to be the next big thing that happens in cost is we'll be doing more outpatient procedures. Now, I'm an interventional cardiologist, just for the audience. That means I do the angioplasty procedure. You're an invasive cardiologist. You do the diagnostic procedures. So most of the procedures that you do are same-day procedures already. The patients go home the same day. But the current standard for most of the interventional type procedures where we do a stent or a balloon is to stay overnight. But many people believe that the next step will be to do those as same-day procedures and send the patient the same day home. And that's a real advantage for the wrist approach. So if you can do the wrist and you know that there's almost no chance of bleeding and you could do a stent and send them home the same day, that's lower cost. The patient doesn't have to spend the night in a bed that's uncomfortable, better for the patient, and it's less cost for the hospital. So I think that the trend will likely push a lot of doctors towards doing this.
Now, because the radial artery, the artery in the wrist is so much smaller than the artery in the groin, is that a comfort issue for the patient when you're moving the catheter around?
You're leading me wonderfully because you're helping me cover a lot of questions that I want to make sure I answer. So your question answers a question I want to make sure I just like, who is the radial artery really sometimes not good for? And that is, I would say, the patients that seem to complain the most about this are younger women. And it's thought to be that the younger women patients their arteries are so active because many times they're healthier, their arteries can spasm and it can grab that catheter that we put in, and when we take it out, that grabbing can cause a fair amount of pain. So we do see that sometimes in younger women with these smaller arteries, because women often will have smaller arteries, and the spasm problem can cause some discomfort. So a few of the patients that have told me, I've had it both ways, I'd rather have it the other way, are younger women patients.
Interesting.
But there are some treatments for that. There are medicines, of course, for pain. There are medicines that we use for relaxation, medicines like Valium called Versed that can help reduce the spasm, medicines like nitroglycerin. There's a blood pressure medicine called Verapamil that we use that can reduce the spasm that we sometimes can use to reduce this problem, but it still is a problem in some patients.
Now you do a lot of your procedures at what we call tertiary care hospitals, and you're helping to train some of the cardiology fellows who are learning how to do this procedure. So do you think that in years to come, because they've been exposed to the radial artery procedure, that the cardiologists in training will preferentially use that, and the percentage nationwide will eventually go up?
I think that, young trainees are always interested in learning new procedures. So one place I go to has really adopted this for some of the cost and safety reasons, and one place has not adopted it at all. So to answer your question, I would say at one place the fellows are going to be well trained in this, and another place they will not be. So I just think that that's so you see around the country there are pockets of places that have said this is really a good way to go, and their trainees are doing it. But your question raises another point I want to make sure I cover, and that's an interesting question, is that I think that patients in the past have sometimes said, I really want to have this done from the wrist. And for me, that's okay because I do it from the wrist, but I would caution patients to say, I really want to have it done, and I really want to have it done at a certain place with a certain doctor. Because if you're asking a doctor to do the procedure that he may not be that comfortable doing, you may be setting yourself up for a problem. I tell patients, for instance, in my conversation when I consent patients for this procedure, that there are two places. One place does this a lot from the wrist, and the other place not as much. So I'm not even sure whether the place that doesn't as much even has the equipment. The day I go, I have to even check to see whether they have the equipment that we need. Right. The nurses aren't as comfortable with it. Sometimes the medicines that should be given during the procedure aren't given because there's just not that much familiarity. So it's an anecdote that I will say to patients that I have a dear friend who was an orthodontist who needed to have heart valve surgery, and he said that he wanted to have heart valve surgery with a robot at a particular hospital. And I said, that's really bad for you to do that. You should go to the doctor and have a conversation about it and say, are you capable of doing this? Are you comfortable doing this? Because the doctor might say, sure, I'll do it, but not be very good with the robot or something like that. This is a conversation that I think this procedure is good. You should have a conversation with your doctor saying, do you do this? Are you comfortable with it? Is the place that you go good at it? And that's a conversation that you should have if you have a confidence in your doctor. But not say, I want to have this and I want it at that place, because you may be setting yourself up for problems. Right.
No, I agree. And I think that the labs that we use locally have expressed a lot of enthusiasm for doing the radial artery approach.
Yes. Well, one of the goals for this, particularly for those heart attack patients, is to be a radial first lab. And one of the local hospitals, the Lawrence General Hospital, has now taken that. All of the doctors who do the heart attack angioplasties take a radial first approach. In most patients, I guess some patients are in critical situations we don't, but in almost all patients we try to do the radial artery first, and with really great satisfaction by both patients. And now that we're in a situation where the nursing staff is comfortable, they're very happy. They would much rather have the patients have the wrist than the groin, because they know there'll be less chance of complications and problems for our patients.
Yeah, absolutely. Whenever I go to the lab to do a case, the first thing the staff asks me is, are we doing this from the radial approach? Because obviously they like that better. And I think part of it's because of the patient experience.
Yes. Well, to wrap up with the patient experience, we'll just show the last picture. So this is what the patient ends up with, is the last picture, if we could show it. It's really a sort of wristband. This is one brand that's used. Is the patient just ends up with a wristband and a sort of an immobilizer to try to keep it straight. And they can sip coffee, eat lunch, use the telephone with your other hand. And this comes off in 1 to 2 hours, depending on how much blood thinners we use. And, it's really a fantastic innovation that we're very excited about.
Yeah, that's great. That's a terrific summary. And I do think it's a really nice approach. Every patient that I've worked with, done a radial artery approach, has really liked it. And the word is actually spreading. I think the newspaper articles are really helping spread the word about how good this is.
Yeah, I think that's one of those things that I also have told some other physicians, like training doctors, as you mentioned. I have mentioned to them in the past that this is one of those things that you almost can't do a little bit, because once you start doing it, the patients are going to find out and they're going to say, well, I really want that, and then you're going to have to do it all the time. So you might as well do it all the time, get proficient, get more efficient so you're comfortable doing it faster. So you're not just doing it a few times where the patient's very heavy and needs to have it done, but you just do it as your preferred approach.
Yeah, and in terms of whether the doctor's comfortable with it, has done enough of them, I guess one thing I would urge is, if you're beginning to do this is you don't do it when you're rushing. You know, make sure you've got plenty of time. It's going to take a little bit longer until you get up to speed. You'll still do it carefully, you'll do it well, but you're not going to be able to do it as fast as you could do the. So no need to rush.
Yes, I think that's a great advice for the doctors in the audience.
That's true. Yeah.
But I would say that I think if you make a commitment to this, any doctor that makes a commitment to this, and you know, obviously is reasonable, previously had good skills, and has a commitment to, you know, wanting to learn, I think in a year the time difference is almost nil. I honestly think that it doesn't take me any longer to do this procedure now after doing this for several years than it would be from the groin artery.
And I agree. And I want the people in the audience to understand that a lot of the skills that doctors have from doing it from the groin approach transfer right over to doing it from the radial approach. So it's not as if you're approaching something brand new.
Right. Great. I agree.
Well, great. That's been a terrific discussion about what we call radial artery catheterization. And I think you can all sense Dr. Bilazarian's enthusiasm about this. So I thank you for watching. This is Kenneth Adams from Pentucket Medical Associates Cardiology, and this has been a Haverhill Community TV program, Matters of the Heart. Thanks very much for joining us.